So good afternoon, everybody. So we had an interesting and a very challenging case, and we thought it would be very nice to present it to the CCR, not only because it was challenging, but it also demonstrates that what all tools we have currently in order to assess the cognitive functions and make a fair prediction of whether patient would be neurologically compromised or not following surgery. And so the question is, if we have somebody like this person, I'm sure all of you would recognize, which is Mrs. Shakuntala, who was a math genius. And if this person presented with drug-resistant epilepsy on a dominant temporal lobe, can we do surgery? So of course, fortunately, we didn't have somebody like her presenting, but we did have someone coming with similar talents, and it kind of really stretched the limits of our capabilities thanks to the multidisciplinary teams available from, of course, from our department, from neurology, from neuroradiology. Dr. Ajay is here, nuclear medicine, and all the other departments. Can you go to the next slide? Yeah. Okay. So we present a case of a drug-resistant epilepsy arising from the language area, from the left temporal lobe in a maths genius. So the whole question was, when we started working up this patient, whether we could actually do surgery and what did we do, and that I will keep it for the climax till the end of the case. So we all know that epilepsy surgery is a comprehensive program which requires multidisciplinary approach, and we are running one of the oldest and perhaps the largest programs in the world and one of the oldest programs in the country along with Sri Chitra. And for the past 10 years, we've also been having the Center of Excellence for Epilepsy, which has had verticals for establishing clinical neurophysiology, surgical programs, as well as a very nice research algorithms, which has facilities for patch clamps, and we have published over 150 papers. And I'd like to acknowledge each of this member from all the departments who have contributed. From neuroradiology, Dr. Ajay, we have neurotechnicians, neuronurses, nuclear medicine, Professor C.S. Bhatt, Dr. Madhya Tripathi, neuropsychology, whose role here is very important, Dr. Ashima Nehra, and of course neuropathology. Nobody can forget Professor M.C. Sharma. He says that perhaps we are slightly important. I think they are the most important people. They have the final say. So now I will request Dr. Raghu to present the clinical.
The patient is a 24-year male who presented to us with a focal epilepsy. The age of onset of seizures is 12 years, and the total duration of seizures is 12 years. And seizure frequency was 1 to 2 per week. Seizure type was focal seizure with secondary generalization. I'll be describing the symptomology in video EEG. Associated history, birth history was normal home delivery, cried immediately after birth, and milestones were normal, achieved at according to the age. And he had one episode of pneumonia at 9 years. He was hospitalized for 20 days and recovered well. And there's one positive history of cousin having epilepsy in the family. He was on 3 anti-epileptic drugs, levetiracetam, oxcarbazepine, and clobazam at appropriate doses. He previously tried multiple combinations prior to coming to our hospitals, and the drug refractory epilepsy is because of no control of seizures with at least, as per the AIIMS definition, 2 drugs at least for 2 years. That is considered as a drug refractory epilepsy. And epilepsy surgery remains the main treatment modality in this case. So coming to this video EEG and semiology, with the due permission from neurologists, we are presenting due to time constraints. There's no options. Okay.
One more. Or you can read.
So the patient was in bed and awake, and he has, to start with, he has relative immobility of the right upper limb with automatism in the left upper limb. Then there was a forced deviation of the head towards the right, and last clonic jerk was on the left lower limb. Based on the semiology, the lateralization was to contralateral signs of right upper limb immobility and posturing, and turning of the head to the right side, and automatisms of the left upper limb. That is lateralizing to the left side. And the semiology is temporal because the prolonged onset before generalization, and that it is more of mesial than the neocortical. This is an ictal onset with rhythmic delta at T1, then obscured by, you can see the muscle artifact and the eye blinking. The ictal progression was basically difficult to comment because of muscle artifacts, the same. And the ictal termination was seen, the delta slowing the bilateral temporal, with amplitude more on the left temporal side than the right temporal. We had another figure which was showing the ictal onset in the form of a slow delta in the right temporal compared to the left side. This is the same progression. So we had ictal semiology that was suggesting to the left temporal, and in one figure we have the right side ictal onset. So this because of this discrepancy of the ictal onset, we did SPECT, and the hypothesis being left mesial temporal onset based on consistent semiology lateralization. The imaging will be presented by Mohit.
So, in all drug refractory epilepsy patients, we do an epilepsy protocol MRI, which is usually a 3 Tesla MRI, which is done with high resolution cuts and thin sections, with corner sections which are required at right angle to the longitudinal axis of the hippocampus. So all these MRIs are discussed with Professor Ajay Garg multiple times before arriving at a final diagnosis. So in our case, this patient had left-sided hippocampal atrophy, and a loss of internal architecture of the hippocampus was seen, which can be well made out in this inversion recovery sequence. You can see on the right the architecture of the hippocampus. The infolded hippocampus is maintained as compared to the left side, which shows
battery approach of assessment and constantly evolve our neuropsychological assessment protocol to live up in line with the AIIMS guidelines. Our protocol is also designed keeping in mind the limitations of time constraint and excessive patient load. The evaluation was carried out in 2018. The objective neuropsychological test results show above average verbal IQ, above average to superior attention, executive functioning, special focus on arithmetical ability, shows that he was performing at a very superior level of ability. However, there was impairment in the visual and the verbal memory, which is and functioning, which shows at a floor level of the test. It basically means that based on the norms, we can see if the patient performance is less than 5th percentile, which shows maximum impairment. However, in follow-up assessment, any further decline if the patient would not be detected by a formal psychometric testing. Coming to the self-report and a subjective evaluation, there was a presence of mild depressive syndrome on screening and subjective reporting of cognitive complaints in everyday life. Now coming to the red flags and the predictive model of memory decline. The predictive model has been developed, and which is developed internationally by the AIIMS, determines red flags that can identify the patient who may be more at a risk of a high cognitive price for unsuccessful epilepsy surgery. However, unfortunately, such a model doesn't exist in Indian context, and is aspirational. With available literature, without such a model, we can still try to mark the red flags to a neurologist and the neurosurgeon. Shibun in 1995 states that a preoperative marker of the structure and the functional integrity of an ipsilateral and a contra hippocampi can predict a preoperative memory decline. Coming to the present case, since he was a case of a left MTS, his score on a verbal memory, which reflects the left side, ipsilateral side of surgery, show low functional adequacy. Further, his score on a verbal memory, which reflects the right side, contralateral side of the surgery, show low functional reserve, which has been identified as a potential red marker for the decline after surgery. However, other red flags as older age of surgery, low functional reserve, or having impaired verbal IQ, pathology, and other hippocampal sclerosis are not present in this particular case. As we stated earlier, it's a mathematical skill, involves the comprehension of written and spoken language, number of processing, calculation, retrieving arithmetic facts, and producing the results in written and in spoken expressions. The calculation skills are per se bilateral, more toward the left and right. He had a unique arithmetic ability, as is stated by my colleagues. Mathematical ability is a very widespread circuit, underpins the exceptional ability of frontal lobe, parietal lobe, huge involvement of the working memory. When such patients are posted to surgery, it's difficult to accurately tell what will happen to the patient after the surgery, especially when it is an unusual case like this. Very few people have it, and since we cannot accurately tell what it really represents, we cannot guarantee that it would be after the surgery he would be at a risk or not. Neurosurgery.
Hello friends.
Very good afternoon. I am Dr. Ramesh from the with the diagnosis of left-sided MTS, we decided to operate this patient on the left side standard temporal lobotomy. We performed this with a mini craniotomy, as already shown there. So, we do this with surface anatomical landmarks, where Sylvan fissure forms the most important landmark, and we plan the craniotomy 1/3 above. We plan the craniotomy just 1/3 above the Sylvan fissure. So we do a 3 by 3 centimeters craniotomy, and we mark the Sylvan fissure. We initially do a recording, following which we do the resection involving the inferior and the middle temporal line. So we do anterior-temporal lobotomy, which is approximately around 3 centimeters on the left side, which is you can extend it more on the right side to 4.5 centimeters. Once the anterior-temporal lobe is removed, we just try to bear the Sylvan fissure, and the next step, most important step, is the identification of the temporal horn. So usually it is identified around 3 to 3.5 centimeters from the pole. Once the temporal horn is opened up, the landmarks like the hippocampus with the head body and the choroid plexus form the most important landmark. So we disconnect initially the mesial structures, particularly hippocampus and the amygdala. Hippocampus is disconnected in a stepwise fashion. We completed the lateral disconnection. Now we are medially lifting up the fimea. Once the fimea is lifted up, the hippocampal sulcus is seen with the vessels. So the most important thing is we don't use bipolar cautery here. We rather use sharp dissection using the scissors, and we try to peel it off from the hippocampal sulcus. The dentate gyrus lies just medial and beneath this fimea. So most important thing is en bloc removal of the hippocampus, including the head, body, and the tail, as much as possible behind. So now we have disconnected the hippocampus. Once this is removed, we continue the dissection posteriorly to include the posterior-most part of the tail, which corresponds to the tectal plate. So that is basically where the hippocampal tail turns into the lateral one. Once this is done, we remove the part of the amygdala, that is ventral amygdala is anyways removed initially. Now this is part of dorsal amygdala which we remove, but we don't go much beyond that because it can go into the basal nuclei. So you can see the third nerve, the PCA and the MCA.
following which we do a watertight dural closure. And this is small craniotomy. As you can see, the closure is also very easier. And this is a post-operative picture showing subcuticular sutures and post-operative scan showing extent of resection, which is going up to the rectal plate. So this basically mini-temporal craniotomy we have been doing since almost more than 7 to 8 years, and we have achieved good results, both cosmetically as well as there is no temporal muscle atrophy and cranial defect as well in the post. So, following post-operative day 1, we actually examined this patient for his mathematical skills and ability, and we tried gave him a questionnaire which he was able to answer, which you can see very well in this video.
Hello friends, मेरा नाम है कल मेरा आज ऑपरेशन हुआ है। आज मैं आपको मेरे बारे में कुछ बताऊंगा। इस बारे में का तो 10 साल की छुट्टी है। आप मुझसे किसी वर्ष के किसी महीने की पढ़ाई नहीं कर सकते। कहाँ से हो? मैं हरियाणा से हूँ सर। आप मैं इस बाजार से आपको 1 या 2 सेकंड तक दे सकता हूँ। अगर आप मुझसे साथ आकर पूछ सकते हो। ओके, मैं आपको डेट बताऊंगा और आप दिन बताइएगा। 3rd August 1988. Very good. 6th June 1985. 1st November 2015. 15 sir. Sunday. Very good. 4th February 1989. 77. Very good.
So as you can see, he is very happy answering the questions as well. And so with this, the post-operative histopathology report came to be as mesial temporal lobe sclerosis as expected, and the patient had a very good outcome in the post. So in the follow-up patient, we have totally a 2 years follow-up, and in the follow-up we did a repeat testing of his cognitive functions. Dr. Ashima will be telling you.
So his mathematical ability was preserved, and now he was on a single drug. He had no subjective complaint of memory or attention anymore. He resumed his studies to and prepare exams for a Patwari examination, and all the special neuropsychological assessment considerations were checked. At a 2-year follow-up, we can see that the neurocognitive domains remain the same range as before. So we can say that the performance was sustained. His arithmetical ability remained the same along with other domains. However, his mood, subjective cognitive concerns, and quality of life improved after surgery. This graph shows the stability of his unique mathematical ability over time since 2008, when he started using this formula. Over the years, even with the change in the number of seizures, the number of anti-epileptic have finally been reduced, and epilepsy, and in 2018 his ability remains stable and intact. So at present he is very happy, very satisfied with his surgical outcome. In spite of the deficits in the objective neuropsychological testing, no subjective complaint given by the patient anymore, and he feels more confident for studying, which he is doing at the moment.
Thank you everybody for that presentation. I'm grateful to all of you. So we published this as a case report. But I think the most important aspect of this case is the need for assessment. And since this is a teaching session, I will ask Raghu to briefly tell you about the function.
Going to the eloquence of the left temporal lobe, we have mainly four regions. One is the hippocampus, which is a mesial temporal structure, which is involved in a verbal memory on the left side, whereas non-verbal memory on the right side. So we are concerned with the verbal memory in this patient. The second is superior temporal gyrus, which is auditory area, and posteriorly it is connected to ventricular area and important for the language function. Third is the lateral neocortex, which is a center for processing the multimodality information like auditory and visual in particular. And the fourth is a basal temporal area, which is important for language processing, particularly visual picture naming modality of perception. So the eloquence of particularly coming to the left temporal lobe, we can assess the eloquence of left temporal lobe by these methods. One is neuropsychological assessment, which we used in this case, and functional MRI, in which we localize the motor and comprehension part of the language, and border test, which is now we are not using it because of availability of fMRI. Extraoperative stimulation, in which we place subdural grids or depth electrodes, particularly in those cases where localization or lateralization is not are in doubt. We use that opportunities to stimulate various areas, and we find out the eloquence of the area, whether a particular area is involved in the language or any calculations. And the third is the intraoperative stimulation. While patient is awake, we stimulate multiple areas, and we see a further function. So this is one study which was published, which showed that functional MRI can predict the verbal memory decline after surgery in left temporal cases. This showed that when a functional MRI denotes the language dominance on left side and patient undergoes surgery, there are more chances of decline when compared to the language localization on the opposite side. So along with that, they also mentioned that a good preoperative performance, late age of onset of epilepsy, left dominance on fMRI, and left dominance in border test. These are predictors for memory decline following surgery. This is another paper which was published, which was showing the yellow area denotes the language area, the red area denotes the episodic memory on the left side, verbal memory, the blue color denotes the non-verbal memory on the right side. So if the preoperative scores are high and WADA memory asymmetry is representing both sides, and the risk is very high, the patient is preserved, the functions are more on the left side. If you go for surgery on the left side, the chance of developing deficits are high. In case the second one, where there is a preoperative scores are medium and the WADA score more on the right side than the left side, the chance of getting deficit are still high. If the third one is already the language function is because of plasticity has shifted to the opposite side as well, and on functional MRI at WADA test, the right predominance is there, and the risk is very high. Particularly in this case, we have bilateral representation of the language, and the scores are average, and this constituted a low risk case. The role of hippocampus, particularly in case of hippocampal sclerosis, they compared the result with the hippocampus sclerosis and without hippocampal sclerosis. The hippocampus sclerosis is usually associated with the severe structural and functional abnormalities in ipsilateral temporal lobe. So in this case, the patient had mesial sclerosis, that is hippocampus sclerosis. So that shows that ipsilateral temporal lobe is involved and already had severe structural and functional abnormalities. And removing those abnormalities can have less effect. This is another study done in children, which shows that whether medial mesial structures are really important. So this shows that this is another study which is role of temporal gyrus, which was showing these are basal temporal areas, which this shows resection area around 4.2 centimeters to 6 centimeters. That is area to be present.
So thank you, Raghu, for finishing on time. to all the team members, even though we had some differences. So I think these are the main take-home messages which I compiled, which are general and also specific to this case. So epilepsy surgery obviously is the only option for drug-resistant epilepsy. Otherwise, his cognition is going to go down, seizures are not going to. Very important for us to understand that drug-resistant epilepsy can be identified early in the course of disease. It's not equivalent to antibiotic resistance, which means that the person becomes resistant to drugs over a period of time and then you consider surgery. No, it's a de novo phenomenon. So out of 100 patients, 25 will be drug resistant and they have to be given an option of surgery very early in the course of disease. Epilepsy surgery is, as you can see, is highly effective in appropriately worked up patients. And as of today, the multidisciplinary teamwork is mandatory. So in this case, obviously, unless we had the complete workup by the entire team, we did not have the requisite confidence to go ahead. And still, then it was a calculated risk. Still, then we had to do proper things. But as of today, with all the available investigations, it's possible to do a proper preoperative mapping of all the cognitive functions, especially with the high-end investigation available. It's very important to provide detailed preoperative counseling to patients and relatives of what are their expectations out of the surgery and what can be offered. And finally, early epilepsy surgery has got excellent outcomes. At the end, I would like to acknowledge each and every member of the epilepsy surgery team. And of course, in my department, I've always enjoyed an exceptional support by Professor Kali, our head. And from neurology, Manjari, she has been one of the pillars for creating this program. Professor C.S. Bal from Department of Nuclear Medicine, Professor Chitra Sarkar and Professor M.C. Sharma now from Pathology, Professor Ajay Garg from Neuroradiology, Madhavi from Nuclear Medicine again, and of course my colleague Dr. Ramesh, who has done this excellent presentation. Dr. Ashima Nehra, as you can see her role, without her role we won't have the confidence to go into this case. And fellows, Dr. Bhargavi, who is now a faculty, Dr. Raghu and Dr. Mukherjee.